Hi, welcome to everyone out there. Again, we're joined by Prestige Genome Care and Quality Insight. Look, this webinar is specifically designed for social workers and discharge teams from hospitals, but look, it is relevant to anyone that works in the sector. We really appreciate the support that we got in the last webinar. We had well over 70 people that joined the viewing of this, and then quite a few after that looked at it post the production of it. So welcome also to anyone that will be watching this past or post this production on the demand piece or either via YouTube. We really appreciate that then. One of the big call outs that came from that is there are plenty of questions that have been developed and asked and brought about. So today, particularly for our section, we're going to go through some of those more commonly asked questions, but we certainly would encourage anyone that's watching now to email through on the chat box where Lisa's dutifully monitoring that. Ask the key questions. Look, the old adage that there's no silly questions, absolutely relevant to this topic as well. There's so much information that's come out to the market since the 1st of November with both residential and home support. It's one of those areas that did seem to be less tricky, but it's definitely not less complicated than it was. So I'm going to jump into my part of the presentation bit, but please feel free to ask those questions. If you're watching this later on and you have a question that pops up, please send us the question via sales@qualityinsight.com or brad@qualityinsight.com, and we'll make sure that we answer those questions. Actually, before I share, I'm just going to introduce Leighton and Brooke and Courtney from the Prestige Genome Care team. You'll hear plenty from them in the second half of this. And of course, I'm joined by Lisa Goff, who's the Ops Manager for Quality Insight. So yeah, the web series on December. So we are at Christmas time and we've had 1 month of the New Age Care Act. And I've got to say it's been relatively smooth sailing from what we see from the consulting arm that we do, but also working within care homes. One of the big things that we have got going right now with Metro Health North is the CareBridge portal. And we're starting to see the traction in that system moving more and more along. For those that aren't familiar with CareBridge Connect, it's a portal interface that runs between the hospital and the aged care provider. And what would happen from there is the hospital discharge or social worker would have a patient that's able to go into residential aged care or seeking home support. That portal is the conduit by which the information is shared to the provider or to the service provider, being home support. So it's becoming a vital cog. And just a bit of an update on that, we are talking to the state government, the Queensland state government, about a larger scale rollout. We're also talking to the federal government about what can happen nationally with this program. So we're very much excited about where this could go to. But more importantly, this does deliver outcomes and it delivers real results. So we're excited by how it's working, and touch wood, the system has not failed once. So from a stand-up digital platform, this thing performs. So we're really impressed and proud of where that's going. Okay, let's get into some of the questions that have popped up that have come across my desk or come across Lisa's. These are the top 4 that have come out, but I'm sure there is others that are there, so please ask them if they're relevant. Security of tenure, are additional service fees compulsory? How do the new fees and charges work? And homes seem to be taking longer for assessment. So I'm going to go through those 4 topics in my part of the section before I hand over to Leighton and the team. Security of tenure. Now, I went through this in a little bit of detail last time, very similar slide, but basically the ground for a resident to be dismissed from the service are pretty well defined. And whilst there's a bit of a laundry list there of different things, it pretty much boils down to the lack of capacity of the provider to care safely for that person, the person putting themselves and others in harm's way, and also people that are doing stuff that's illegal within the care home and potentially causing more bodily harm. So there's a couple of big trigger points as to why a resident can be removed from a residential aged care setting, but there are certainly a lot of protections in and around that. So the resident must be given 14 days notice. And it's not just the 14 days notice they've got to be given. They've also got to be given an alternative, a suitable accommodation for them to go to. So this is no different than the old rules or the pre-1st of November rules. The provider had the obligation to find another care home that was suitable. But where the beefed up piece here is that they must have a suitable accommodation with a signed agreement. So it's very important that from a social work team that you understand where these rules are so that you can also push back if you're getting people put on your doorstep. There's lots of continuity of care obligations as well that the providers must do. So they must show they've considered how to deliver alternative solutions within their own care home, and these must be noted as well. So if the commission or the regulator comes through to investigate, there must be all efforts made to make sure this person has been safely and carefully looked after, even though they might be a bit disruptive. So they certainly just can't be dumped into a hospital. On the respite front, the biggest key change there is if a person under respite goes into a hospital for a night, they're not automatically discharged from the residential aged care service. So again, another area where in the past we may have seen people discharged back to hospital under respite and then terminated from service. That certainly can't take place anymore. So there's a couple of key trigger points around security of tenure, and really happy to explain that in more depth for if there's any more specific questions around that. Lisa, did any questions pop up as we were going through that part?
Just the one, just requesting a copy of the slides at the end of the presentation.
Yeah, absolutely. And actually, I should have mentioned before, we've developed a cheat sheet newsletter that is going to come out. So one is based around the Resi Aged Care information shared, and I'm sure the Prestige team will help us sort out something in a home care sense. But yeah, you are going to get the slides. High everyday living. So the next bit is around that additional service programs where pre-1st of November, aged care providers could charge a mandatory fee for coming to service of $20 a day, $40 a day, and that was supposed to cover additional services within the care home. They are no longer allowed to do that. It must be by residents' choice, and there are a number of consumer protections that are put in place. So from the 1st of November 2025, any new residents entering into aged care have the choice of whether they take up the higher everyday living program or not. The additional service and extra service programs are now null and void, except for those that have been in care pre-1st of November. They've still got a transitional period, but any new entrant, they've got to be under the new higher everyday living program. There's a couple of big consumer protections around the health program. The first one is that residents that choose to partake in those services have a 28-day cooling off period. Once they've served that 28-day cooling off period, which they can get out of those services with no penalty, they then move into a 28-day opt-out. So an example of that is if they're 6 months into their stay and then they decide these programs are not for them, they can just give a minimum 28 days notice and then they can be removed from those services and have no obligation to pay for them. And there's certainly no precursor to a bed offer around additional services. So it's a separate thing altogether. The agreements are very separate. So if a provider is saying to a patient, come into care, you can come in, but you need to pay $30 a day health program, that's against the rules in the legislation. So can be very much policed around that. Big call out around high everyday living. If someone comes to hospital, their program is suspended whilst they're in hospital. They are not obligated to keep paying for that because they have no access to those services and there's no derived benefit from them. So another key change in how this additional service area works. Lisa, any questions pop up for that one?
No, nothing at the moment.
Good. The new fees and charges. So again, we've got a pretty in-depth cheat sheet that's going to come out around the new fees and charges. Look, the big ones around here is the non-clinical care contribution and the hoteling contribution. Both those fees replace something or are at a replacement of a supplement. So the non-clinical care contribution is the replacement for the means-tested care fee, essentially. So the federal government are paying for all clinical aspects of care in residential aged care. The consumer that's deemed to be able to afford it, so they're means tested, will then have to contribute for their non-clinical care aspects. And that could be up to $105 a day. It's capped at $135,000 as an overall, or 4 years, whichever comes sooner. So that's a definite fee that's mandatory for anyone that's been means tested to deem to be able to pay that. The second fee is the hoteling contribution. It again is means tested, but where it's derived from, it was a supplement given to residential aged care providers to improve the quality of food and hotel servicing. That got lifted recently from $10 to $22 a day. And now anyone that's deemed to be able to pay that under means testing potentially will pay from $1 to $22 a day. There's no caps or annual caps on that. It's pretty much, if you're means tested to pay that, you pay that. So it's really important for residents and patients to make sure they're updating Services Australia every 6 months or so, because that then potentially could reduce those fees and charges that anything that's means tested. The only other one from there that do have some changes is in the accommodation. There's what's called a RAD retention being introduced. So 2% up to 5 years is retained by the provider for anyone who pays a lump sum. So that's a big change there. And also daily accommodation payments are now indexed. So whereas in the past they were fixed, so if someone came in on the July 2023, they might have a fixed rate for their entire stay. It's now indexed, so their fees and charges will change. In fact, a resident will see their fees and charges change at least twice a year through indexation of basic daily fee, hotel and contribution, non-clinical care contributions, and any accommodation that they are paying out of pocket, and any high everyday living fees they could be paying. So their fees will go up as the indexation rates go up. So it's important to have that noted for anyone coming through. Any questions on that, Lisa?
No, nothing.
No. So as a visual, anywhere where there's a green tick is an out-of-pocket expense for a potential resident in residential aged care. You'll see on the extreme right here under high everyday living, there is no obligation to pay it. So people have a choice to pay that fee, but basic daily fee, everyone pays it. Hoteling contribution under means tested, high means residents will pay it. Non-clinical care contribution under means tested, higher means residents will pay it. And under accommodation, there'll be out-of-pocket expenses for high means and moderate means residents. So it can be a little bit tricky in that fees and charges space, but teams are slowly getting their heads around it now. The final question that came out is around clinical assessments. So this is part of the reason why we developed CareBridge in the questioning that comes out of it around the clinical assessment questions, the criteria, the different paperwork that's required for that assessment to take place. And it all falls under risk and care minutes, mostly for the aged care, residential aged care spaces. So residents that are deemed to be high risk or complex care needs potentially will be a cost detriment to that residential aged care provider. So they're not potentially going to have the amount of funding that they're required to look after that person properly. They also may not have the fully trained staff or the number of staff to meet their mandatory care minutes models as well. So they've got a couple of different spinning plates that they're considering when they're bringing a patient through the door. So in the old days, and I'm talking only 2 or 3 years ago, you could have a patient present to a residential aged care provider. They would look through the ACAT. They may ask a couple of questions around behaviours, and 9 times out of 10, that patient would potentially flow through to that resi aged care provider based around the choice of that patient and their family. Now we're seeing it flip to where it's quite difficult to get a bed, not because there's not a number of beds available, it's the right bed for the right patient. So they're considering a lot of other metrics when they're doing these clinical assessments. That's why it's so vitally important to make sure that the information supplied is up to date, accurate, and it's the right information that's coming through. We're seeing under CareBridge Connect a couple of requests for additional information, but it's not a lot. There's not anywhere near the numbers that I would have seen in the past. And my experience has been in an executive sales and marketing manager in Resi Aged Care. I would spend half my day asking why a patient has been rejected, and usually get the answer there's not enough information, or they want more, or the information's not clear enough. Whereas now I'm seeing through CareBridge Connect that's definitely reduced. So there's the right information is being put through there. The other big piece is around suitability as well. If the aged care provider gets the wrong resident through the doorway, and I'm not talking about just someone who's low means or anything like that, I'm talking about someone who's quite disruptive. There's psychological safety in the workplace that's now under consideration. These providers don't want to have large turnover of staff because residents are difficult to manage. So they're also walking that fine tightrope between how they bring that person, look after them appropriately, and make sure they don't damage staff on the way through. So there's a couple of those things that are very much in the picture when a facility manager or a clinical manager are assessing a patient for suitability. I would be more than happy to answer loads of questions around this assessment criteria. And if you do have any, please email me through or on this webinar, ask these questions as they pop up. But it's really vital to understand what's happening in the Resi Aged Care space as to why things have slowed up slightly, if not dramatically, in some areas as well. There are certainly those that would ignore an email or ignore a phone call because they're doing other things in the care home. That's why we looked at the portal to make that as a central point where we know when someone's actually clicked on a link or moved it to the next stage. So try and improve that communication flow as much as we possibly can. Lisa, any questions that have popped up during that piece?
No, nothing new, Brad.
Great. Well, I've got off easy there, Leighton, so I think I'm going to hand over to you and the team. I'll stop sharing this one and get you to share yours. While Leighton's doing that, it's a really vital cog in the CareBridge portal that we've got there around the home care link. And it's something that we see is it's going to have to be an organic pathway or a natural pathway that if we've got patients sitting in hospital beds that potentially can go home, that they should be able to go home under home care support, even for a short period of time. So that's where we're quite keen to make sure we've got providers like Prestige on hand to help educate and navigate what that looks like. And the information that we can collect actually might make better decisions for people moving forward. Mate, are you good to go?
We're just having a little bit of trouble. Hopefully won't be too much longer.
That's all right. Well, while we got Courtney, Courtney there, we might ask some questions. So, Courtney, we were talking a little bit off air around the clinical assessment that people would undertake when you first go out and meet them. Can you sort of talk through some of the steps that your team looks at when they're coming into someone's home environment? What's the assessment like? What's the risks, all that sort of stuff?
Yeah, sure. So if we're doing a clinical assessment, we're meeting someone for the first time, our clinical assessment framework would cover 4 domains. So the first one would be sort of a physical wellbeing assessment, which would include pain, respiratory symptoms, oral, delirium, and nutrition assessment. We'd do sort of assess the skin head to toe. We'd do some vital signs if they were necessary. The second domain would be around sort of social wellbeing, sort of how we can support the family and the emotional and social support that's missing and we can provide. Also covering practical concerns too. So things like, access to incontinence aids, slide sheets, all those types of things. Thirdly, we'd assess sort of the psychosocial well-being, covering sort of anxiety, depression, symptoms and distress, so how we can offer support in that regard too. And the last domain would be under spiritual well-being. We do an assessment and sort of try and find out more about the spiritual beliefs, faiths and traditions that the person and their family want to follow.
Yeah,
We'd
so
also
it's quite
sort
a
of
holistic sort of approach.
yeah, and we'd also get a good idea of what supports that the family or carers can offer, and what's missing, and that's where we would come in and try and work out where we can support with what's missing.
Yeah, great. Looks like Leighton, you're good to go.
Are we good to go?
Yeah.
Where is that? Okay, thanks guys for that. Yeah, great to see you all again, and thanks for the opportunity again for us to share our palliative care and end of life support that we do have at Prestige. So here's the contents that we're going to discuss today. So about Prestige in home care, understanding home-based palliative care, our approach to supporting palliative care, end-of-life pathway through support at home, and Prestige expertise in palliative care and end-of-life support. So just a bit of a brief rundown. I think I mentioned this last time, but we are a family-run business. So Nick McDonald and Thea McDonald, brother and sister team, all family-run. We've been 20 years. We've just had our anniversary in Melbourne. So head office is based down in Melbourne and Moorabbin. We have 4 offices down in Victoria, Bayside, Mornington, Geelong, and East Melbourne. We also work here in Sydney in Bondi Junction, and also on the sunny coast. We have an office there in Sunshine Coast as well. I am coming up to Brisbane next week to visit you lovely people up there in this very hot, steamy environment you guys live in. So we've got a great reputation here for service. Our clients obviously come first. We do comprehensive in-home care support, full spectrum of domestic and personal care services, specialist expertise that we're experienced in palliative care, dementia care, neurological disorders, and continuum of care. Services range from social through to meal preparations through to nursing. So understanding home-based palliative care. So what is home-based palliative care providers? So a personalised and compassionate model of care we deliver to people to feel safest in their home. It enables people to remain in the familiarity of their surroundings. It provides them comfort, dignity, and emotional reassurance. We align with cultural, spiritual, and personal preferences as well, and we focus on symptom management and quality of life. To reduce unnecessary hospital admissions, that would be a main aim. So supporting families with dignity. So we are family-centred, so the care that reduces stress and we preserve meaningful time together with family. It's a guidance through decision-making, emotional and psychological support to families, respite options to relieve caregiver burden, respectful, culturally sensitive practices before and after death. Patient-centred home care. So the care is tailored to the person's wishes and values and their preferred routines. So an integration of cultural, emotional, and spiritual needs, a continuity of care with familiar nurses and support workers. So there is a familiarity. We keep the same carers and nurses with the patient as much as we can possible. We do have a backup team that they'll also meet, and there is familiarity with them as well. So we really believe they feel most comfortable when they know that person, obviously. Maintaining autonomy and independence where possible. Collaboration for seamless care. So collaboration, we work with GPs, specialist palliative teams. We work with pharmacies, allied health and hospitals. We all work together with the patient at end of life. So Prestige, we do act as the central communicator for any updates and changes. We obviously notify the family and next of kin. So medication management is another part, monitoring supplies and equipment arrangements as well to support safe care at home, to reduce confusion, duplication, and we help them navigate the system, which is a real burden on families. So our approach to supporting palliative care. So the care looks like at home. So it's flexible service aligned with stage of illness. Okay, so what needs and family capacity. So nursing, for example, symptom assessment, pain management, medication administration. We even work with syringe drivers. We can work with anything nurses could do. Wound dressing example. Personal care, which is hygiene, grooming, positioning. Pressure relief is a big one, and massage. Short visits. So obviously we can work from a 1-hour service at Prestige to 24/7 end-of-life palliative care. So household assistance, we can work with domestic assistance, meal preparation, like domestic support, like cleaning around the house, family guidance. So we do allow the families to be involved with the care as far as what to expect and how to recognise any changes and who they are to call. So, you know, a point of contact is essential for the family members. We also encourage the family to enjoy special quality moments with their loved one. Core services, so comprehensive support throughout the entire palliative journey. We ensure the comfort and dignity in the final stages of life. We respect their cultural rituals and preferences. Coordinating with funeral directors, medical teams, hospital teams, we assist with families immediately after death, presence, reassurance, and next steps. So there is a continuum of information for the next of kin and family, emotional support and continuity for families processing loss. So we are experienced with palliative care. In fact, we receive a lot of end-of-life palliative care through our hospital networks, especially here in Sydney. We work a lot with the Sydney Adventist Hospital, Prince of Wales Hospital, St Vincent's Hospital, and a lot of smaller private hospitals, a lot of rehabilitation hospitals as well. So experienced palliative care specialists, comfort and confidence, flexible tailored care, future planning, and we also assist them with funding guidance, how to navigate the system, because that is a burden at end of life for anyone. Government funding. So end of life pathway. This is a pathway that sits on top of support at home. So there is an end of life pathway. It's designed for people with 3 months or less to live who want to remain in the comfort of their home. There is also a one month extension available if they are to live longer, hopefully. It provides up to $25,000 of funding over a 12-week period for personal care, nursing and equipment. So works alongside the state-funded palliative care services. So key components, integration of GPs, specialist palliative care teams, and community providers for seamless care. So this is an important pathway that now sits on top of support at home. There are 3 pathways in total, this being one of them, $25,000 funded immediately, of course, at end of life. There is the short-term restorative care pathway and assisted technology and home modifications pathway. So there are 3 new pathways with support at home. So here's the support at home end of life pathway. Eligibility, certification by a medical practitioner or nurse practitioner, funding as a one-off budget of $25,000 over a 12-week period, access existing participants, transition into the pathway through a high priority support plan review, access new participants, submit a completed end-of-life pathway form, including medical certification, care delivery, service delivered in accordance with the National Support at Home Services List, and exiting. So participants exit the pathway. If they pass away, they no longer want to remain at home. Their medical circumstances change. The funding period ends. Providers request a support plan review to convert pathway to ongoing supports. Onboarding new referrals. So clinical desktop review, telehealth consult determines clinical care and forecasts care management requirements, face-to-face sign-ups, review and approve care plan and budget. Existing support at home clients. So care management and case and clinical to conduct a case conference, clinical conduct face-to-face review of clinical services, and case manager to do a face-to-face review and clinical consult via telehealth if needed. Care planning actions, symptom management, psychological support, end-of-life care, advanced planning, and tools. Prestige, expertise, and palliative and end-of-life care. So why partner with Prestige for the end-of-life pathway? We have a proven track record supporting families through their final stages, ability to activate urgent services quickly. We're compassionate, culturally sensitive approach. We're high touch. Communication reduces hospitals, treating team burden. Dedicated pathway coordination for supported home referrals ensures dignity, comfort, and choice at end of life. So funding options, private or self-funded care, also government-funded options with supported home with the end-of-life pathway through My Aged Care. Easy referral steps. So referral hospital submits a referral via CareBridge Connect. Review, Prestige reviews referral and patient information. Planning, care and funding options discussed with family support plan created. And care at home, patient discharged, Prestige provides in-home care with ongoing supports. So we just want to thank you so much. If you've got any questions, we are happy to answer them. And we've actually got Courtney available as well, who's happy to answer some questions for you.
Yep, great. Thanks, Leighton. I haven't seen any questions pop up on the live chat, but
yeah,
if there is any questions out there, please send them through. And as I said before, if you're watching this recorded later on and you've got some questions, please send through your question through to the team. We will share the slide decks of both the residential and the home support piece, which has got contact details on it as well. But I suppose, Courtney, just to elaborate more on the question I asked pre-Leighton's presentation around that, what happens in the support at home mechanism. So can you talk through once a client comes on board with the home care provider, what can they expect in terms of service and follow-up and backup? Because I know one of the things that sits in the back of the discharge planner's mind is, what is the backup for these people? Because they're obviously coming out of hospital, they're going to a home environment where there's not as many eyeballs on them as it would be in hospital. What can they expect from the home support team in making sure these people are well protected?
Yeah, sure. So it really depends on if the participant is new and accessing the end-of-life pathway without having access support at home before, because we're finding that those clients coming on board are needing a lot of things set up. So they're needing a lot of support in terms of hiring equipment, sort of referring to allied health. They're needing a lot more support, whereas participants who already moved from support at home to the end-of-life pathway, they're a lot more sort of set up, ready to go. So in terms of our support, it's sort of case by case, but we can sort of, for some clients, we're providing a lot of coordination in the background with allied health teams and specialist palliative care teams. And we're doing a lot of work sort of depending on the next of kin's availability and their ability to help, and also their ability to understand the whole support at home system. Because if you're new to it, accessing the end-of-life pathway, we're finding that we're having to provide a lot of support to the families on the system, navigating it and understanding the different processes. And but one thing that I just thought I'd mention is the equipment. So there's a misconception that equipment is part of the end-of-life funding. and it's actually not. So it's just one thing that people in hospital staff should be aware of. If someone is applying for the end of life pathway, the person has to know that their equipment hire is a separate funding scheme. So that's under the Assistive Technology and Home Modification Scheme, which end of life participants can be approved for, but only the low and medium tier funding levels. And they just need to make that known at the assessment that they need equipment, because we're getting referrals in where people have got no equipment and no funding for it, and they're having to pay that privately until a support plan review's undertaken. So, yeah.
Yeah. We have a question in here from Kira. Bit of a long one. So with palliative care, timing can be difficult to predict. What appeal options are there for people who unexpectedly need more time? Or where do they transition if no longer eligible for palliative support?
Yeah, that's a really good question. So in that regard, so when someone is assessed for a end of life pathway, if they're not a participant already, they're given a supported home category, a level to revert back to if they do exceed the 12 weeks. So if the person is expected to live beyond that 12 to 16 week mark, they can revert back to a supported home package. So there always is that option. It's just up to their care partner to be putting in that support plan review and really working closely with the families, understanding the client, how the client is and what's happening, to be able to predict that they might need to go back onto a supported home package. But
I think it's just
they can only access this end of life pathway once.
Yeah.
Yeah.
And
It's
like
also
everything,
important
sorry, Brooke.
Sorry. That's okay. It's also important to add in as well that they do have up to 16 weeks to use that funding too. So I think if the client was to come close to that sort of end of cycle for the 12 weeks, we'd look to extend that period. So like Courtney said, we'd ensure that we were doing those sort of regular reviews to make sure that that budget was going to sustain as long as possible.
Yep. Yeah. We've got another question there. Is there an expectation that of end of life package contract is signed with a provider within a certain number of days after the package is approved?
I would imagine so, yes, as immediately, ASAP.
Yeah. Yeah. And like everything that we're in aged care, we're quite confident, aren't we? So,
yeah, we recently had a case where we had someone that was referred, they contacted us and wanted to use us, but they weren't sure when to activate the pathway because they know that they've only got 12 to 16 weeks from there, and his prognosis was kind of a bit up in the air. So you're also finding some hesitancy around when people actually want to activate or start it.
Yeah,
it's a really tricky area.
I've also had some information regarding people that are not registered, but they are at end of life. They still qualify for the end of life pathway. So if they don't have a supported home package already in place, don't give up. Go for the pathway.
And imagine, Leighton, that could be triggered through GP or a nurse practitioner, like you've said previously.
Absolutely. Yep. Yes, absolutely. I've got a friend of mine who's in this situation at the moment, whose parent has only been given weeks to live and is not working, doesn't have a supported home package. But I said, you go back to the social work team at Nepean Hospital and get something in place, because they were just going to fund everything themselves. And, it was just, it's just more pressure.
Yeah. We've got another relevant question along that is, when does the 12 weeks start? Is it the day the package is approved or the day the contract is signed with the provider?
That's a really good question. I understand it to be the day
of services commencement.
Yes, yeah. But it's something
the day approved.
Yeah. I would say service commencement.
Yeah.
Right.
Once the
Yeah.
actual services like can be approved, as soon as the services commence, it would start from then.
Yeah. I'd imagine the
And
agreement
again,
would spell that out.
yeah,
Yes.
that is something that I think we manage every day with support at home, and previously the home care packages as well. It's kind of that trigger date is, you know, if an agreement's signed, it's going to outline exactly kind of when those services are starting, and that would trigger that period.
Yeah.
And that's really important with the quarterly budgets that we're working with at the moment as well.
Yeah.
Yeah. And I think this stems back to
I mean, we're in a lucky
like-
position here in Sydney. We work closely with a lot of hospitals here, and end of life palliative care is a lot of the referrals that we're getting.
Yeah. And I imagine this steps back to, I know on the radio this morning in Brisbane, they were talking about NDIS is now looking at robots for assessments and all that sort of stuff. And I think this is really important to point out that the businesses that we operate and run within are very personal. So we're not looking at digital robotic systems to replace this. Everything we are talking about is about communicating as people and humans to each other and understanding where people are at. Because in that palliative care pathway, and I'm actually in that now with my father, it is tricky. Like you got to be able to disseminate a whole heap of information very quickly and try and make the right decisions. So you need to partner with people that understand this properly and reach out.
There's so much emotion. There's so much emotion around end of life. I mean, my mother also was at home in her last days, and you know, you're spending those precious moments with that loved one, with that parent, in my case, and you don't want to have any other stresses or pressures on you. That is just your last moments of time to spend with family.
Yeah. Well, it sounds like that this still is a pretty hot topic with these webinars. We had a lot of questions in the first series, and we've got some now. So I think what we'll endeavour to do is put together a fact sheet that we can also send out. But I would encourage, we are going to run another webinar series in January. It just won't be early January. It'll be mid to late. Hopefully everyone's back from leave. But if there are any questions in relation to people watching live now or watching on demand later on, please send them through, because we'll certainly make sure that we get them answered for you. And as I say that, we've got another, if a patient is approved for end of life package, but the family does not want to access this for another 4 weeks as extended family support, does this mean the 12-week commences only when the service provider is engaged? And I think that we answered that around the signing of an agreement, and the agreement would spell that out. Is that right, guys?
That's my understanding, Brad.
Yeah. Yeah. So I think
Courtney,
yeah, I just, it's something that I just would like to check, and because I think, I'm not sure if, you know, if something like 4 weeks would be, there might be a timeline around it has to be activated within 2 weeks. So it's something that I'll look into, and we can include it as a part of the feedback.
Yeah.
Yeah. Brilliant. Okay, guys. Well, we're nearly at our allotted time slot there. I'd like to thank the team from Prestige Genome Care and Lisa for joining me on this webinar. Really valuable insights. Thank you to those that have asked questions and those that are watching live now. And also thank you to anyone that's jumped on and watched this after production. We will share the slides. We will share a fact sheet around these bits and pieces, and we'll announce the next webinar over the next couple of days once we've sorted out what leave looks like. But I'd like to take this opportunity to wish you all a Merry Christmas and have a happy and safe holiday period. And hopefully at the hospital front, you are not bombarded with a whole heap of people that you're just going to pull your hair out over. So wish you all the best. Team on the webinar, thank you very much. We'll do it all again in a couple of weeks. Take care.
Thanks, Brad. Thanks, Lisa.